Next, we will call upon Professor Yogesh Sarin, who is a very good friend of ours and a pediatric surgeon and a professor of pediatric surgery, to speak on common curable cancer, the Wilm's tumor.
Thank you very much, Dr. Gopinath, sir, to invite me to this. And last few lectures that I've heard, I mean, I'm totally impressed and floored. We surgeons, we are different. We are very flamboyant at times. We are very aggressive and at times very self-obsessed as well. We don't understand cells too well, but when it makes a tumor, we love to go in and do some experiments surgically. So I'm going to talk about a very small little thing in the tumor that is known to be the best epitome of tumor management in solid tumors in children. That's Wilm's tumor. We have had the best of cure rates in that. Abroad, US, etc., the cure rates are as good as 90%, and we are also kind of coming close to that. Provided the patients do not abandon the treatment, we can probably, using the same protocols that were developed in the West, can have the similar results. So, can I have my first slide, please? What is it? So, we all know that the radical nephrectomy, mind it, emphasize on the word radical. If you read textbooks, they all talk about radical nephrectomy or radical nephrouretectomy. And I have seen the patients being operated in the world and all over the world. And I've never seen radical nephrouretectomy in the last 3 decades at least. There's usually a simple nephrectomy, people go into the Girota's fascia and do the rest. So this word radical nephrouretectomy has to be thrown out of the textbooks, and I keep on repeating this to the masters of the game. I also agree that still the total nephrectomy is considered to be the gold standard whatsoever for Wilm's tumor. Having said that, we will talk about today to do nephron-sparing surgery in unilateral, non-syndromic, preferably non-metastatic Wilm's tumor. That's a concept which probably came out with the Italians way back in 1991. And how we learned it was, we were all anyway doing bilateral Wilm's tumor. Rickham in 1956 said, if you have a bilateral Wilm's tumor, the larger one should be removed, and the opposite side, you should do the partial nephrectomy. But over the years, by the time 1990s, it became very clear that you have to do partial nephrectomies on both sides. So we were doing partial nephrectomies for bilateral Wilm's tumor. So this is one of the cases which I had done about 4 years back. We give preoperative chemotherapy as per SAP protocol to all patients. They shrink at times. And they don't shrink at other times. We do not know. We need our biologist friends to tell us which one will shrink and which one will not shrink. Because which one is not going to shrink, there's no point wasting 4 weeks or 6 weeks of chemotherapy before we take up this patient for surgery. So we always do a renal dynamic scan to prove that whatever functions were there before were retained post-op as well. And this is another case. Similarly, the tumor shrinkage was rather more, 31%. And again, the renal functions were kind of preserved for both sides. From these ideas, we had the idea of doing NSS in unilateral Wilm's tumor. And there were other factors also which kind of emphasize that we should be doing NSS in unilateral tumors. Experience with NSS for RCC in adults showed many, many advantages. Metachronous bilateralization has been seen so many times, especially if the resected specimen shows nephrogenic arrest. Hyperperfuse nephropathy is known, and we know that early stage CKD happens. So ESRD is still the second most common cause of death among WT survivors. So long-term renal adaptations happens much better with doing nephron-sparing surgery rather than total nephrectomy on that side. So all these reasons kind of gave us that impetus that we should do it. In India, as of now, only 2 surgeons. One in Belgaum is doing NSS. He's an adult urologist. And within the pediatric surgery fraternity, I'm the one who's been doing it for the last few years. I tried a multicentric kind of project, but it didn't fail because people are still not learning how to do it. They're probably not even convinced that they should be doing NSS in unilateral tumor. So way back, they kind of had surgical selection criteria and radiological selection criteria of doing partial nephrectomy in a unilateral Wilm's tumor. So they said if it is a polar tumor, just occupying the 1/3 of the kidney, you save 2/3 of the kidney. That was the major thing. But there should not be any involvement of renal vein or IVC, and you should prove that the nodes are not kind of affected already. So those things have been changed over the time, and then they started saying, okay, tumor volume even up to 50% is acceptable. Now there are papers available from Italy which says that even if you can save 20% of the kidney with a Wilm's tumor, you should save every nephron that is possible. And this is the umbrella protocol by SIOP, which was expressed in 2016, and they started recruitment in 2019. They said if the tumor volume is less than 300 ml before any therapy started, and lymph node negative status is proved at the time of the surgery by doing a frozen section, and there is a substantial remnant kidney function remains, then you probably can do NSS if you are knowing how to do it. So this, as I said, the thing started way back in 90s. Italians were the first one to report in 1991. So partial nephrectomy was considered about safe in approximately 10% of Wilm's tumor by the end of this previous century. So now we know that you know, the indications have changed over the years, and now people say that you know, more and more people say that overall survival with partial nephrectomy, unilateral Wilm's tumor is equally good. Recurrences are rather less. I mean, the Schamberger, who used to be the chairperson of NWTS at one time in 90s, wrote an article that why you should not do NSS is because the recurrences will be more, and when you give second-line treatment to these patients, the overall survivals are less. But now it is well known that the chemotherapy for Wilm's tumor is very efficient, and even if the surgical margins are positive, there's no harm done and overall survivals don't go down. And more studies are coming which says that at least 50% of the kidney in question, if can be saved, one should definitely do nephron sparing surgery. In the total scenario, there's a paper in 2012 from USA that says that about 1/4 of the patients can be amenable to NSS. There's another paper which is very important for Poland, which says that NSS represents sufficient treatment in 93% of the children with stage 1 W3. This is because they identify their Wilm's tumor very early, when they are small, so probably NSS is very much possible. Although I'm a big proponent of the same, but in my case, in my clinical services, the tumors that come to us are very, very large, and usually the Wilm's tumor have actually replaced the whole of the kidney. So obviously in those you have to do total nephrectomy. Since last 7 years I've been doing NSS. About 25 to 30% of the patients only are amenable to NSS, but whenever they are feasible, we always do it. There was another issue they talked about, was that probably lymph node understaging happens, but that's wrong, because instead in NSS we actually send the lymph nodes even for frozen section. So the first step that we do in the surgery is not doing partial nephrectomy, but to remove the nodes and send it for frozen section. So this is the study which came out from India, the first in 2014 by Nerli. And Nerli had this tumor maximum size of 7.5 into 6.8 centimeters that he did the NSS. And he would use the creatinine clearance and 12 months follow-up. He never used the renal dynamic scans to prove that he's doing a good job. The same gentleman came out in 2020, a very nice RCT between total nephrectomy and partial nephrectomy, and that's the only RCT that is available in the world, which says that NSS has much better results in the long term as regards the presence of ESRD in long term and the use of antihypertensives, need of hypertensives in these patients. So I will quickly go on to this. This is the umbrella protocol I was talking about. If you would see on the right side of your screen, you see polar resection, enucleation, wedge resection, and excavation. I mean, these are different terms that have been used in surgical books. But what umbrella protocol said is that either you can do a partial nephrectomy. The surgical margins, how much to cut along, is not very clearly given in the literature for the Wilm's tumor. I mean, now they say even if you have 1 millimeter good margin, this is good enough. But in many of these patients, even enucleation has been. So since 2018, I have done about 13 patients, in which I have almost in about 8 patients done inoculation, because there's a good plane which is available outside the pseudo capsule, and none of them have had recurrence in these many years. So, but you have to document that whether you have done an NSS-A, which is partial nephrectomy, or NSS-B, which is inoculation. So I will just go through some slides and finish up with that, because we are already very late on the. So this I've already talked about. Schamberger mentioned about surgical margin positivity creating problems, but there are a lot of papers available which says the surgical margins are no problem at all. And these are the, okay, so I'll just talk about the protocol that I use is that we do a routine and metastatic workup, including CECT, chest and abdomen. Ultrasound guided core needle biopsy by retroperitoneal route is done in every patient. This may be controversial statement, because now SIOP and COG have come very clear indications. But we must understand the non-Wilms renal tumor are more common in India and East Asia as compared to the Europe as well as Europe. So we are about 20% of the renal tumors that come to us in India, they are non-renal Wilms tumors, where the pre-op chemotherapy for the Wilms is not going to work. So we always do a core needle biopsy, and we have a study done by which core needle biopsy could give us the good results in most of the cases. So then, according to the SIOP protocol, we give neoadjuvant chemotherapy, and then we always repeat a post-chemo CECT and also do a renal dynamic scan to know the functional status, because we want to compare it with our results post-op. And then we do intraoperative assessment of partial nephrectomy with frozen section. And frozen section is also taken from the surgical margin. We don't need to be egoistic here. If we think that we want to do partial nephrectomy but intraoperatively we feel that we cannot do it, we must go on to do the total nephrectomy rather than risking this patient for a recurrence. And then we do follow-up RDS at completion, and then we go on to do the post-op adjunct therapy, whether if this patient needs radiotherapy to the flank, that means the saving that little kidney is no good. So we should be very sure that this patient is not stage 3, the lymph nodes are not involved, the margins are negative, and I'll go on to this few cases. This is a large tumor which is sitting on the left side. The tumor volume is 390 ml, more than what limit the SIOP has set, 300 ml for us. Minimal size tumor reduction happened after giving the preoperative chemotherapy. This is the SRF which we did before and after, which shows almost similar results. This is case 2, where again there is a tumor on the left side. Here minimal tumor size reduction happened. We went ahead and did a nephrectomy for this patient. So 3D reconstruction of CECT would be nice. Some people are now talking about doing 3D imprinting and all that, which is an overkill, I think, when you have to do NSS. This is the RDS before and partial nephrectomy. So the function is retained most of the times. This is another patient which is a large tumor and which had but significant tumor size reduction after pre-op CT. This is the 3D reconstruction that has been done, and we could save part of the kidney. This is to show you that the so-called pelvis calyceal system involvement becoming a contraindication to doing NSS. That's really not so. You can actually excise the bit of the kidney along and then suture that pelvis over a stent, and this patient has been operated 5 years back and has been doing so well. So most of the contraindications to NSS which are mentioned in the books, most of the contraindications that are mentioned for NSS in the books are, you do more and more NSS than you realize. I've done NSS for multifocal Wilms tumor on the unilateral side. You may ask me why, because that's mentioned as in contraindication of the protocols. But these are the patients which have nephrogenic arrest. These are the patients who are going to have metachronous tumors. These are patients who will eventually go into ESRD and would need renal transplantation, which is not going to be very easy in an Indian setup. So we would do even NSS in a multifocal. The youngest child that I have operated NSS in a Wilms tumor is 3 months of age, child of a doctor. And the largest tumor that I have done NSS on a unilateral size, the volume was 800 ml. So all these things are very much possible. It's just the mind block that you can't do it once you start doing it. So I've offered to most of the pediatric surgery friends that I'll come with my own expense to teach you if you want me to. But the response has been glim. But I've been delivering this lecture, almost 40 of them in different countries, SAARC countries, India, repeatedly. So as people pick up this little contribution to the science that I could do. Thank you so much.